Start. Oh,
Good evening, doctor, and welcome you for the meeting webinar. Doctor completed both MBBS and MD in St. John's Medical College, Bangalore, and DNB in New Delhi, and also completed fellowship in diabetology as well as clinical cardiology. And today's topic is type 2 diabetes and cardiovascular disease, a serious complications. And madam, over to you, madam. You can start the session.
Okay. So, good evening to all of you. Really glad to be part of you all in this part of the session. And for a few minutes, I will give my expertise opinion on this cardiovascular complications related with the type 2 diabetic. So, thank you for that great introduction. So, I go into the topic. So, I want to talk to you on type 2 diabetic and cardiovascular, a serious complication or not. Yes. First of all, we all know we as the Asian and Indian populations are growing in not only in our population, but also we are growing in lot of non-communicable diseases. That is, most common is type 2 diabetic and many cardiovascular diseases. So if we see here, we almost reached 101 million burden serving with type 2 diabetic in India. And we need to also understand not only having type 2 diabetes, but how are the complications related to this. And very much poor glycemic control has a lot of side effects related to this. You can see in this graph here clearly, even if you try to control the patient's sugar, if they are not taking medications or not complaints to doctors to come and take the medicines, or they themselves stop the medicines, even for 6 months to 1 year, they go into a lot of complications. So if we see a significant increase in risk of Wikipedia study shows myocardial infarction almost 67% in persons and 64% have heart failure and stroke 51% and almost composite with all this patient have lot of other complications. So if we see, it's type 2 diabetic when we think it's not only just the hyperglycemia, that is sugar high. So if we bring down the sugar, it's alone enough, all that. This sugar high, that is hyperglycemia or diabetes, what happens to each part of the organ, we should be aware of it. That's the main discussion I want to tell you all today. So it's not just isolated disease that it affects only one organ or one particular problem. It
Madam,
has,
Madam,
yes.
sorry to disturb you, madam. Madam, ஒரு 2 minutes, madam. Live கொஞ்சம் இது ஆகலையா, play ஆகலையா? ஒரு 2 minutes, madam. Update
Oh,
பண்றேன்.
சரி, okay. So, attenders சேர்ந்து ட்ரை பண்ணிட்டு இருக்காங்களாம்.
மேடம்
எஸ் டெல் மீ.
மேடம் இப்போ இது ஆயிடுச்சு மேடம், சரி ஆயிடுச்சு.
சரி ஆயிடுச்சா?
கண்டினியூ பண்ணலாம் மேடம்.
கண்டினியூ பண்ணவா?
கண்டினியூ பண்ணலாம் மேடம்.
சரி. So thank you for the IPACO and Kurekannan team for giving me this great opportunity to present on type 2 diabetic and cardiovascular disease as a serious complications. Thank you for that great introduction. So I go ahead with the slide presentation. So if we see the high burden of diabetes in India is keep increasing, almost 1 billion is being found to have type 2 diabetes. Even 1 year of poor glycemic control found to have lot of the significantly increased risk of complications. So you can see here almost 67% goes for myocardial infarction and 64% for heart failure and 51% goes for stroke and 62% patients can go for all composite of CV events. So type 2 diabetic, if we see, it is not just only hyperglycemia where patient is having high sugar, only we need to target that. But this hyperglycemia overall can affect all the organs. So it can affect kidney, it can affect cardiovascular, and even it can affect the liver and even the peripheral neuropathy, all can develop. So how this is happening? This type 2 diabetic, whenever the hyperglycemia constantly present in the body, the endothelial cells goes for inflammation and it goes for the deoxygenation. And when patient is having weight gain, they have automatically goes for all these related complications. And this type 2 diabetic is commonly associated with a lot of other diseases like hypertension, cardiovascular risk, and adiposity and insulin resistance. And here one more is missing, that is PCOD also for patients who are on reproductive age. So if we think of type 2 diabetic, we have to always think of just a holistic approach of taking care of the patient. So it is not just one dot where you need to just to see one dot, but you need to see the patient as a whole, seeing multifactorial and person-centric approaches very much needed. So if we see here in this graph, what is this metabolic memory? So here metabolic memory means whenever any patients who comes to you with a type 2 diabetic newly diagnosed, immediately if you take care of them with the intensive therapy, the inflammation, the endothelial breakage or oxygen species that is present in the body is going to reduce and the complications at a longer time is going to be very much less. So because the glycemic effect that is being very controlled in the early age within 1 year or 2 years, that is remembered by the cells. That is called metabolic memory. In another word, it is called as legacy effect. So if we see here, the tight glucose control within 1 or 2 years when patient is newly diagnosed, instead of saying your HbA1c is only 7.5, it is okay, you can wait for till it goes for 9 or 10, then the patient's complication is going to be much more higher. That's what this UKPDS study showed. Within over the 10 years of the patients, they went ahead. And the patients who are in conventional therapy, that is very lightweight, their reduction of the complication was equal to the patients, those were with intensive therapy, those were very much in control. Their side effects or their micro or macrovascular complications were very much lesser comparing to them over the 10 years. So if we see here, 24% of reduction was found with patients who were in intensive therapy found to have reduced reduction of microvascular complication, and 15% of the patients had reduction in myocardial infarction, and 13% reduction in all-cause mortality. So you can see here, HbA1c to start with conventional therapy or intensive therapy, they had almost 6.5. You can see gradually it increased, but the complication almost has come to the same. But if we see here the yellow, that is intensive therapy, their complication was much more lesser. So if we see the hyperglycemic as a cardiovascular risk factor, you can see here as UKPDS study, it clearly shows when the patient's values of less than 6 to 10, if initial treatment was earlier, their reduction of myocardial infarction was increased with more than twofold. Even 1% HbA1c reduction matters a lot. That is what we want to say again and again. So if we see here, what is the common pathophysiology of type 2 diabetic and cardiovascular disease? These are the main status, how this goes for acting in the body. If the patient is having insulin resistance, that is the most important antecedent of type 2 diabetic and cardiovascular death. If you see inflammation, there is a very strong relationship that has already told you in the beginning itself. The insulin resistant states, inflammation gradually breaks down the endothelial tissues of the all the organs, like renal endothelial tissues are broken down or the intestine is being broken down. So patient gradually goes for the lot of gastrointestinal issues or lot of stroke or MI, all that. So this is inflammation that happens in the particular organs. And if we see oxidative stress, you can see here chronic oxidative stress contributes again the return to insulin resistance, type 2 diabetic, and cardiovascular disease. Even hypercoagulability happens when the platelets are enhanced activation of platelets and coagulation factors also happens. And even because of the uncontrolled type 2 diabetic, they can go for higher hypertension, type 2 diabetic, and risk of cardiovascular. As we told, this all acts on the endothelium mainly. And even dyslipidemia, we all know there is a very, very major link between diabetic and increased cardiovascular risk of diabetic patients. Obesity, we know nowadays it is not called as just a diabetes, it is called as dia-obesity. So if you find a patient with diabetes and obesity, you need to be very, very careful in treating them the obesity as well as treating them the diabetic to not to lead them into a lot of complications. So if we see here, management of stage 2 cardiovascular kidney metabolic syndrome. This is metabolic syndrome, hypertriglyceridemia and hypertension. All this has a very major factor which contributes to the patients for their worsening of the symptoms. So now what is this metabolic syndrome? We all need to know this metabolic syndrome is very much a serious effect to be taken care early enough. If we take care of them early enough, then you can find that it is very good in control. Now, what is this consist of? This the metabolic syndrome. If we see, the patient has actually having the insulin resistance, and they have also increased triglycerides, and they have like many other diseases like hypertension, triglycerides are very high, and even LDLs are high. Like that, the 6 parameters gives us a metabolic syndrome. This metabolic syndrome has to be taken care very early stage. Immediately, then the better outcome will be there with the patient. If we say hypertriglyceridemia, this also gives for increased atherosclerotic cardiovascular disease, and it is very much frequently associated with metabolic syndrome and insulin resistance. This again hypertension, if we see when the patient is being not controlled with a diabetic, automatically like a co-brother or co-sister in the family, the diabetic patient also goes for hypertension. So along with all these diseases, major factor to play is lifestyle modification, very, very important here. so that it can metabolic syndrome can reduce the inflammation, hypercoagulability can be reduced, and endothelial dysfunction can be taken care. So if you take care initially with all this controlling of the blood pressure, controlling of the glycemia, and controlling of the lipids, all can be taken care. If you see hypertriglyceridemia in any patients, as always with the lifestyle modification, first line therapy, you have to start with statin also if you see the patient has higher risk. So if you see triglycerides more than 500, then automatically you have to start for the fibrate also, because there is high increased risk of pancreatitis to develop for the patients. So if you see triglycerides between 135 to 1499, you can always start with isopenteethyl, that is ISA, that is also very good for the patients to prevent them for the cardiovascular diseases. So the target for ADA or European guidelines gives very clearly patients who are with type 2 diabetic, blood pressure target is less than 130 by 80. So you can start with the RAS inhibitors and clear them from the albuminuria also for these patients. So now, how do we manage? As already I told you, first of all, achieve the maintaining a healthy weight and healthy proper behavior, and recommend the patient for regular healthy lifestyle, go for regular walking, exercise. Not only just walking, you have to explain to them for muscle building, and isometric exercise also matters a lot. And stress management, because type 2 diabetic, not only because of the sugar, is because of some irregularity, even the stress factor leading to cortisol. The newer octane, that is omnious octane, what we see 8 pathways, is added with that now is actually cortisol. So the stress management is most important, because whenever patient is having heavy stress, automatically cortisol is going to go higher, and patient is again going to for hyperglycemia. And you also need to help them to stop the smoking, alcohol, and to have a proper sleep. And always target your HbA1c less than 7 and blood pressure less than 130 by 80. And what is the lipid lowering? Already, as I told you, immediately if you see your patient is with type 2 diabetic, your total cholesterol is above 200, triglycerides above 150, immediately start the medication. And whenever you see, even if you see LDL is very higher, like more than 150 or 200, please start ezetimibe to start statins to prevent them from cardiovascular diseases. And what is the anti-hyperglycemic that you want to start? Nowadays, we have a very good products, SGLT inhibitor and GLP-1 analogs, very much advised for reduction of cardiovascular risk and the morbidity and mortality being reduced with this medication. So these are the protective treatment for the second stage of cardiovascular kidney metabolic syndrome. So this is the algorithm which was given by the many guidelines. You can see here hypertriglyceridemia, as already told, if more than 500, start with 500, if less, if between the 135 to 499, be aware of the pancreatitis and start with EPA. That is very good. And I have given many patients with the EPA. It is very good for the patients, and they come within 1 month very much reduced with triglycerides. And even hypertension, you can start with the AC inhibitor or ARB inhibitor. Even those who are with the CKD stage 2, you can always give AC inhibitor and ARB inhibitor, because albuminuria being reduced and patients' outcomes are very good. So overall, the lifestyle modification matters a lot, and moderate to high intensity statin has to be started. So we need to understand lower, moderate, and high intensity statins are there, and high intensities are atorvastatin and rosuvastatin, and moderate are other statins. So you need to be careful in patients what type of statins you are starting with. Okay, and ezetimibe is specifically given for the patients who are already with the cardiovascular risk, and if you find the ejection fraction lower, better add with the ezetimibe also. And always consider HbA1c to be keep with less than 7.5. If you find more than 7.5, you can always add with dual drug or triple drug combination to reduce the complications and to control the diabetic. If we see stage 3, cardiovascular kidney metabolic syndrome, it is many patients are prone for subclinical CVD and risk equivalents to as in all the other stages. So if we see this is coronary angiogram scoring. If they find more than 0, always start with statins of you can always start with it. If you find cardiovascular calcium scoring is more than 100, always start with aspirin automatically. If they have low bleeding risk, they do not elderly not having any bleeding risk, then automatically you can start with this medication. And even nowadays, the PCSK9, that is acetaminophen, and GLP-1 analogs can be started. This is very good for this. And if we find patients are having heart failure, always give the AC inhibitor, AR inhibitor, and beta blockers has to be added to that. And even nowadays, HLT inhibitor in ADA and ACA guidelines, it is being given very clearly. So we can add to reduce the risk for them to hospitalizing very often, and morbidity and mortality can be reduced with even stage 3. So very much early treatment matters a lot. And we can also, very high risk CKD, you have to always predict them with a calculator and find out what stage are they and how to treat them. This is the treatment protocol which has been given here. And if we see here in the patient with the stage 4, already stage 4 is patients who are with cardiovascular, kidney, metabolic syndrome along with cardiovascular risk. If we see here, their framework is very much matters. Life's essential aid framework. What is this life essential aid framework? Is mainly eat better, be more active. That is lifestyle modification, like going for regular walking, exercise, all that, and quit completely tobacco and alcohol, and get at least minimum 6 to 8 hours of sleep, and manage weight control in production, and cholesterol has to be controlled, and blood sugar has to be maintained, and manage blood pressure to be less than 130/80. And whenever we need to use a proper valid tools to understand how the patient has been properly maintaining and to understand this, to reduce all this co-existing factors for the diabetic patients. And aspirin and high intensity statins for all patients in stage 4 has to be started. Even adding with estimabase is most important for lowering the LDL cholesterol. So this is the algorithm for how to treat the patient with stage 4. You can see here dysfunctional adiposity. So patient will, most of them will be heavy weight. So you need to reduce their weight. Weight loss has to be advised, and GLP analogs have come. If their BMI is more than 35, please do add on GLP analogs. And you can see here, even hypertriglyceridemia, as already I told you, that has been treated. Hello? Hello?
Yes, madam.
Can I continue?
Continue, madam. No issue.
Yeah. So if we see the pressure, always as we told earlier, the PP has to be less than 130/80 has to be maintained. And even chronic kidney disease, you have to keep in mind at least once in 3 months you need to go for urine albumin creatinine ratio. But once they have gone for stage 4, maintain them at least once in 3 months or once in a month, and look for AC inhibitor AR inhibitor to be given very carefully. If their urine albumin creatinine ratio and eGFR is more than 30, you can continue with the AC inhibitor and ARB inhibitor. If it is lesser, better to stop the AC inhibitor, ARB inhibitor, because they will go over hyperglycemia, and again that will, hyperkalemia, that will again go for heart failure or sudden cardiac arrest. So we need to be careful once we administer them with the CKD patients. So ARNI is another important drug which is very good for with patients who are with reserved ejection fraction. And in CKD patients also, it is being told, with or without diabetic, you can give SGLT inhibitor as heart failure. It has improved the status of EF from 30 to 45 or 45 to 55. So it has been accepted by the ADA guidelines, the newer 2026 guidelines, which has accepted SGLT inhibitor for heart failure and even CKD patients. So we can give this very much for the SGLT inhibitor. And but only thing you need to rule out that patient should not have pyelonephritis or recurrent UTI. In that condition, you need to be careful. And so diabetes, if we see, of course, we need to reduce with the lifestyle modification, and metformin can be given, and maintain the HbA1c less than 7.5. That is very much important. So multiple comorbidities in the settings of diabetes and CVD, always SGLT inhibitor and GLP-1 analogs plays a very important role in reducing their hospitalization. So this is SGLT inhibitor. I just want to give you a few words on that. So this is very much novel class of oral agents of for type 2 diabetic patients. It specifically acts on renal proximal convertible, which is responsible for approximately 90% filter of the glucose reabsorption taking place. So if we see pleiotropic benefits of SGLT inhibitor, you can see very clearly it almost acts on everywhere. You can see it acts as an natriuresis and reducing the preload. So cardiovascular benefit is much better. And you can see here inhibition of SGLT inhibitor acting on the decreasing the sodium in cardiomyocytes and increasing the mitochondrial function and increasing the calcium homeostasis. So it improves the heart muscles to function better and even decreases the blood pressure via reduction of afterload. And modulation of mitochondria takes place, so oxidative stress decreases and inflammation overall it reduces by the weight loss and epicardial fat can be reduced, uric acid being reduced, and hematocrit has been improved. So you can see overall the coronary atherosclerosis reduces. So overall the heart benefit remodeling and the very much of the diastolic function and the systolic function improves and arrhythmia has been decreases. So that's how SGLT inhibitors, whether patient is diabetic or not diabetic, you can always give. If we see here dapagliflozin, we can see here according to this study with a preserved ejection fraction, reduced ejection fraction, it's very much found, DAPA has found HbA1c reduction very good, and even fasting glucose has been reduced, even body weight has been reduced, and it has a lot of function along with the other formulation. So this is specifically dapagliflozin with the cardiovascular outcome trial. You can see in this almost 18,000 patients were studied, and only 7% of patients had eGFR less than 60. So you can see over the 4 years, dapagliflozin over 10 mg versus placebo, they found that the hazardous ratio was comparatively lower in DAPA and placebo had this one. And you can see even cardiovascular death was reduced. You can see here, even lot of metabolic associated cardiovascular events has been reduced and ischemic stroke had been reduced and death from cardiovascular disease also has been reduced. So here we can see the dapagliflozin has a very good effect along the heart to play a major role in protecting and preventing them to have cardiovascular attack or epilepsy. So this is other trials which has been found in the which was done, and it has found almost 4,000 patients were done where the cardiovascular death or hospitalization was very much reduced in all this. So you can see here in patients with heart failure and reduced ejection fraction who received DAPA, the risk of worsening of heart failure and death from cardiovascular causes was lower than those received placebo. So here what we want to say overall is DAPA plays a very good role. So if we see DPP-4 inhibitors, cardiovascular effects, you can see here also it acts in the intestine, incretin enhancer, it acts on the pancreas to stimulate the beta cells to produce insulin and increases the insulin, decreases the glucagon. So hyperglycemia has been reduced. You can see overall weight neutrality and vascular effects are very good. So even sitagliptin, many trials has found that it has a very much not only reducing HbA1c. Over the 3 years, they found that even cardiovascular events has been reduced and hospitalization for heart failure and other events has been reduced with this study that is called as a TCOS. So I want to tell you take-home messages. First of all, whenever you find any patient, even HbA1c 7 or 6.5, advise them strictly for lifestyle modification and advise them for early prevention is the first step we need to take. And next thing we need to keep in our mind is legacy effect. So early treatment always, strict treatment always keeps them for the future not to go to hospitalization or for the death with a cardiovascular related disease. And always keep in your mind HbA1c to keep behind less than 7 and lesser the complication, lesser the HbA1c is better. And the early strict DM controls always reduces the risk of all our cardiovascular related events And renal protection also plays a very much good role with DM control. And morbidity, mortality, hospitalization is always reduced with early DM control is much most important. And another thing is SGLT inhibitor plays a very much role. Whether patient is having diabetic or not, you can always start with the patients if they have already found to have cardiovascular risk or even cardiovascular failure like preserved, reduced ejection fraction or preserved ejection fraction. You can always start with the SGLT inhibitor because it plays a major role. But before starting all these, rule out the contraindications. Hope you understood. Any questions?
Thank you for your wonderful talk, madam. Is there any questions? Okay, madam. Madam, no questions, madam.
Okay.
Once again, thanks for your wonderful talk, madam. Thank you.